So the question was to talk about durability, stroke, PVLs and patient predictive mismatch in TAVI and SAVR in head-to-head. We think is a very relevant topic in the current eras because this is where our MDTs are for a large set all about. Here's my disclosures. So I think actually we're talking about lifetime management of aortic valve disease in young patients. That's actually what's behind here. And you see there are two major questions. What type of prosthesis to implant and which prosthesis to implant first? What procedures to do first? And the most appealing concept for me would be only one intervention if possible, and should a second intervention be needed, percutaneous approach. Second surgery seems less appealing. So I've shown this slide before. This is the outcome of surgical aortic valve replacement in the Netherlands with a very low 120-day mortality, below 1%, and 1-year mortality rate of 2%, and a very low, very high freedom from 5 years from valvular reintervention, about 97%. And this is the more recent data showing comparable. So this is data cohort in the Netherlands of all surgical aortic valves 2018, 2022, showing again very low mortality with a 1-year mortality for the entirety of all the Dutch heart centers, somewhere between 2 and 5% on 1 year. But actually also TAVR has shown shifting towards less high-risk population, also a very low 30-day mortality and a very low 1-year mortality rate. So both are doing actually quite fine at the moment. Although it must be said, survival data after current TAVI is very limited. So what's reported in literature, the 10-year survival rate, as thus far reported, is as low as only 14 to 35%, depending on patient age. So the treatment focus is shifting. Treatment focus should shift. It shifts from the first intervention to also taking in consideration the second aortic valve intervention. So to taking care of bioprosthetic failure, regardless whether or not the first intervention has been a surgical aortic valve replacement or a TAVR valve. And there is an absence of robust data and guideline recommendations, as well as the clear indication that the first intervention prosthesis type might have in facilitating versus complicating the second intervention. So TAVI in 2024, I think we're talking third generation balloon expandable SAPIEN valve, SAPIEN 3, SAPIEN 3 Ultra. We're talking core valve, Evolut R, Evolut Pro, and Pro Plus. So these are all the major trials on TAVRs that were published semi-recently, shifting from high-risk patients to intermediate to low-risk patients, from partner 1A to 2A to 3, and the Evolut trials. So here's all the current outcome, and I will come back to this in more detail because. So this was the partner 3 data at 2 years, and you saw here if you compare mortality, stroke, and reintervention as a composite endpoint in the partner 3 data, low-risk patients, saw that there was an advantage of TAVR over SAVR, which was 17% versus 11.5% at 2 years. Actually, mainly driven by rehospitalization rate at the moment. I do like to focus, shift some focus to, are we really talking isolated SAVR, even in the partner 3 data? Because in the supplement data, you see that there's a large set of concomitant surgery. Almost 13% of patients in the partner 3 surgical arm had concomitant CABG. There were MACE procedures, there was left atrial artery amputation, but also there was ascending aortic replacements. So septal myectomies, carotid intervention. So we're not talking isolated SAVR. It's good to keep that in mind. If you compare the data, if you look at the partner 3 data, it's not only isolated SAVR that is assessed here, which is a completely different subset of patients. So if you look at the Evolut low risk at 3 years, here the surgical arm does a little bit worse, but you see superiority of the TAVR over SAVR after 3 years. Disability. The combination of the composite endpoint is significant. However, the all-cause mortality rate and the disability stroke rate is not significant. And then last year, we got the 5-year partner 3 data and the 4-year Evolut data. And in that data, we showed that TAVR has lost superiority over SAVR at 5 years. And there's a high number of deaths after TAVR, but it's mainly non-cardiovascular. I think, and if you look carefully at the data, it's very interesting that you see if you do a kind of a landmark analysis, you see that things are shifting. So mortality rate and stroke rate after the first year actually is lower for surgery than for TAVR. And rehospitalization rate is comparable after the first year. So the main advantages in the partner 3 data of TAVR over SAVR is limited to the first year of treatment. So this is about durability. So if you here look at the 4 years Evolut data, still shows superiority of TAVR over SAVR. The curves keep being parallel. And here you see the structural valve deterioration rate in the 2A and the SAPIEN 3 registry. So it's not the partner 3 data. And you see that in the latest generation, SAPIEN 3 has a very low rate of SVD at 5 years. But of course, this is very short follow-up. But there doesn't appear to be a problem of SVDs at early follow-up. So, all in all, I would say that TAVI is non-inferior to SAVR in low-risk patients, but there are a lot of caveats at the moment. Long-term valve durability, if shifting to younger patients, is still a question mark. We don't know. The use, it's good to emphasize that bicuspid valves, which are very prevalent, especially in younger patients, were excluded from the TAVR trials so far. It could be coronary access issues, especially after valve-in-valve TAVI. And there's a risk of embolic event, which might be higher, and a need for permanent pacemaker implantation, depending on type of prosthesis. I'd like to take you a little bit back in time. This is from Joanna Tackenberg from the Netherlands. She does a lot of computer modeling on valve and on valve durability and valve choice. And this is in non-elderly patients below the age of 55. She looked at all-cause mortality for the study population, so young patients receiving aortic valve replacement against the general population. You see that the survival is not the same. It actually has like a 13% 20-year survival differences in favor of the general population. And if you stratify according to age group, 25, 35, 45, and 55 years of age at the moment of surgery, you see here there are lifetime risks for events, and you see the risk of reintervention and structural valve deterioration, even in the 55-year-olds, is as high as 55 to 60%. So valve durability really is an issue, and probably the main issue in non-elderly, low-risk patients. So this is from Joanna Chekwi's group, who's shown that bioprosthesis implantation rate increased between 1997 and 2014 from 14 to almost half, and probably now it's even more. And if you look at outcome, there was no mortality or survival difference between patients after biological or mechanical AVR, which is actually comparable to the studies that our guidelines are based on. But there is a significant reduced incidence of bleeding and stroke in the use in patients that receive a biological prosthesis. However, in line with Joanna Tackenberg's data, there is a significant increased risk of reoperation, which is almost 25% at 15 years, compared to only 9% in mechanical valves, of course, based on pannus formation or endocarditis. So now, if you now go back to that issue of the second intervention, this is nice. Tarantini published this in JACC Cardiovascular Intervention last year. It's a very nice combination of all the available data on the sequence of first and second intervention. So you see the top bar to the left is TAVR first, and the lower bar is SAVR first to the left. And you see that if you do a TAVR first, you see that the bar is divided in in-hospital mortality, 30-day mortality, and 1-year mortality. And you see that the procedural risk or operative mortality rate of TAVR first is very, very low. So mortality in TAVR is very, very low. And if you do in the second intervention, if you do a TAVR after TAVR, the procedural risk is very, very low. 1-year mortality rates up to 5 to 10%. If you then do SAVR first, you see SAVR also has a little bit increased risk here in the data for mortality. But if you redo that with a SAVR after SAVR, that mortality risk is very, very low. But if you do a TAVR first, that's the interesting part of the top bar. If you do a TAVR first and you replace it by a surgical aortic valve, mortality rate is up to 15% in hospital and up to 20-25% at 1 year. And the other way around, you see here in the lower the reintervention rate. So they propose this scheme based on low-risk patients with a life expectancy of, let's say, 20-30 years, the low-risk patients with a little bit reduced life expectancy rate, and the higher risk patients or older patients. And their proposition is, and I think that's very valuable, they say in the low-risk patients, first choice is SAVR. And either a mechanical or a biological TAVR, friendly SAVR. So if you want to implant, if you implant a biological valve in younger patients, you should have a TAVR next option. So there are some prostheses still that were on the market and not implanting anymore today, like the MitraFlow or Crown prosthesis with externally mounted pericardium. They are not TAVR friendly, so you shouldn't implant that in low-risk patients if you want to keep the option of a second intervention TAVR open. And if you have a redo in these young patients, first choice would be a redo SAVR, or as a second choice, a TAVR in SAVR in these low-risk patients. Second choice is a TAVR, and if you have to redo that, it should be a TAVR in TAVR. But you also have to pay attention to what kind of transcatheter valve you implant. Then if you go to the second group, the patient group between 65 and 75 years of age, the same, SAVR is still first choice with a biological TAVR-friendly SAVR, but then the second intervention would be a TAVR in SAVR, not anymore a redo SAVR. And the second choice in general would be TAVR, and then a TAVR in TAVR as a first choice. And then in the elderly population and a high-risk population, TAVR is obviously first choice of treatment, and a reintervention should be TAVR in TAVR. I think this mitigates a lot of the risks that I'll show you in a sec. If you look at the second intervention, this is the 5-year follow-up from the Part 2 aortic valve in valve registry by Rebecca Hahn for degenerative SVR. And here you see the risk, the composite endpoint of risk, that of stroke, up to 5 years, about 54%, depending on the size of the valve at first implant. And I want to take you to this part. This is interesting. This is from Hirji et al., European Heart Journal, 2020, and it assessed the hospital outcomes and readmission rates for valve-in-valve transcatheter valves versus reoperative SAVR in the real-world data. And let me show you this. So this is the 30-day mortality rate of the valve-in-valve TAVR after SAVR. I've showed you before. The risk of 30-day mortality rate is very, very low. 30-day morbidity rate is very, very low if you compare that to SAVR, and a major bleeding rate if you compare that to SAVR. But if you're going to reoperate after a previous TAVR, this is from Jawicz et al. In JACC Cardiovascular Interventions, you see here the operative mortality rates and morbidity rates defined if the patients at second intervention are still classified in low, intermediate, or high risk. And if you here look at the risk, observed mortality, and even, so this is interesting. So patients received a TAVR first, and at the moment of reintervention, they were still considered by STS score a low-risk patient. Observed mortality for a redo SAVR or root replacement is up to 14%. So it's a really elevated risk of mortality, even in low-risk patients. So this is the caveat if you want to reintervene on the previous TAVR. So this is what Hawkins showed in JACC Cardiovascular, the reduced surgical rate, and this is some worrisome things. If you look at the rise of reoperative AVR in the STS database, you see that the reinterventions on prior TAVR are, of course, reoperations after previous SAVR are still very, very high, but the rise of reinterventions on TAVRs is really strong in recent years. And here you see, if you combine the data of, and if you propensity match them, if you do a TAVR, TAVR first and then a SAVR after, mortality rate is 11.3%, and if you redo the SAVR after SAVR, the mortality rate is only 6.7%. And then the other worrisome thing is about coronary access. Although the technology to facilitate this is really emerging, there's still a problem with sequestration of the aortic root and coronary access if you do a TAVR after previous SAVR. And this is also something to really keep in mind when planning your first and second intervention. So in conclusion, I think TAVR and SAVR are both safe and excellent treatment option in current eras, but long-term valve durability of TAVR still needs to be proven, and treatment focus should focus on the potential second intervention, not only on the first, the treatment of bioprosthetic failure, regardless of whether the first intervention was SAVR or TAVR. Thank you very much.
Thank you very much for this talk on lifetime management of aortic valve disease. Maybe there are questions from the audience regarding the initial topic, which was paravalvular leak, durability, permanent pacemaker. Any questions from the audience in this regard, TAVR versus SAVR? If not, okay.
There's one there.
Yes, please.
Thanks. You quoted a study of Joanne Chikwi comparing mechanical to tissue for long-term mortality. That's only one of several, most of which show that actually in the under 65s, mortality at 15% is lower in the mechanical group. So forget second intervention, just have one lifetime intervention, which is a mechanical valve AVL in the under 65s.
Sorry, I didn't get the...
I think I didn't get it, Norman, either very well, the question with the...
No, you mentioned the study of Joanne Chikwi looking at long-term survival, comparing mechanical to tissue valve, remember?
Yeah.
Right, well, I'm saying that's one paper. Most of the literature suggests improved survival at 15 years in the under 65 if they have a mechanical valve compared to if they had a tissue valve. And in the randomized study, which also showed improved survival, the need for re-intervention on the valve at 15 years in 500 patients was zero. So what I'm saying is in a young patient, irrespective of the problems associated with warfarin, which may be clearly serious, you know, my own personal view is if you're under 65, you should have, if it's acceptable with the patient, a mechanical valve. And that would be one lifetime intervention. You wouldn't have to think about a second intervention.
Well, I think it's an interesting point. If you look at the European guidelines, the most recent ones, actually they quote on all the data there is on the choice of I didn't show on the slides, but all the data there is on the choice between mechanical and biological valves. There are two studies referenced. One is a meta-analysis of 4 papers, and there's the Goldstone paper, which is a cohort. And actually, only the cohort of really young patients shows a survival advantage of mechanical valve over biological valves, but over the age of 55 it disappears. So only in the really young, and it's probably below 55, there's a survival benefit of mechanical valves, but not over the age. There's no data showing robustly that over 55 there's a survival benefit of mechanical valves. And here comes the problem: how many patients do we have that get valves implanted? Of course, below the age of 55. There's a very small subset. So I think that data. Well, you should look at the references in the European guidelines. It's very interesting. So there's only one piece that shows it, and all the meta-analysis actually is based on only one RCT, and the rest are observational study. And the meta-analysis fails to show survival benefit. It's on the Stazzano paper from Italy. It fails to show survival benefit of mechanical prosthesis over biological prosthesis. So I think it's an interesting topic. I don't think there's survival benefit.
We're gonna have to cut this argument short, Norman. We're going to have to cut this argument short because we're running late and we didn't cover the main subject of the talk, but we learned about lifetime management without considering, we spoke about mortality of the procedure, but not about morbidity. So we didn't speak about the stroke, about the paravalvular leak, and about permanent pacemaker at the time of implantation. But we'll leave this for another time. Thank you very much.